Good afternoon. Today is June 23rd, and here we are in another community chat. Today, we're going to be talking about listen to your heart. It's the title for today. Why? Because we're going to be talking about heart disease and congestive heart failure and how we get to that. A lot of people in the United States actually suffer from heart disease, and it's the #1 killer in America. So of course, we want to know what's happening, how to be aware, and what do we need to do so that we're not one more victim of that disease. And today with us, we have Darren Moray, and you probably, if you follow the community chats, you probably have seen him before. You know, he's a wonderful speaker and he knows his topics very, very well. He has accompanied us in the past, but nonetheless, I'm gonna still ask him how he started working with us here at Montefiore Nyack, and anything you want to tell us about you. Welcome, Darren.
Sure. Thank you. Thank you very much, Sandra. It's always a pleasure to be here. So I'm a nurse. I've been a nurse for 14 years, roughly 14, almost 15 years. And I spent most of my career in Ridgewood at Valley Hospital. Oh, here's Dr. Murthy. Good. Hi. I came here last year as the heart failure and stroke navigator. And then I've since been promoted to stroke and sepsis outcomes manager. So I'm here with Dr. Murthy, who is one of our heart failure specialists.
Hi, everyone.
Yes, and I'll let her introduce herself and then we can get started as well.
Okay, great. I apologize for running a little late. We had some patient care issues, but my name is Sandhya Murthy. I'm a cardiologist who specializes in congestive heart failure. I work predominantly down at Montefiore Medical Center in the Bronx, but I see patients in Nyack as needed a couple times a month to try to make sure that we're getting the quality heart failure care everywhere, not just in the big cities, basically.
Mm-hmm. And now that you just said, you know, heart failure, let's start with the question. So it's heart failure and congestive heart failure the same?
Yeah, so we use those two terms interchangeably most of the time. Congestion just kind of signifies the symptoms that are associated with it. But yes, CHF, HF, heart failure, congestive heart failure, all referring to the same condition.
Okay, and what is that specifically? We hear that a lot, but you know, it's so many different diseases of the heart.
Yeah, of course. And of course, you know, when you say congestive heart failure, it sounds very scary, but basically congestive heart failure is really a condition where your heart is unable to pump enough blood to the rest of your body. And what that means for you is that, you know, you would have symptoms like shortness of breath, maybe you feel tired, you struggle maybe with fluid retention. So these are all symptoms of the one idea that, you know, your heart is just not able to get the blood that it needs out to the rest of the body.
Mm-hmm. Are there different stages to heart failure?
Yeah, and you know, the one thing that we realized that there's a lot of, you know, predisposing conditions that we want to be very aggressive in treating, you know, before it turns into heart failure. This is an idea that, you know, kind of preventative medicine, that there's things we can do now when patients are healthy and well to prevent the progression of this. So accordingly, we've kind of developed these stages. This is the ACC-AHA stages of heart failure, where it's A through D. Stage A and B are what we call kind of preclinical disease, meaning that you have risk factors, but you don't really have any symptoms yet. So the risk factors, what are they? They're high blood pressure, they're diabetes, you know, you may be a smoker. You know, these are all preconditions that kind of predispose you to the development of heart failure. But you're fine. You're walking around, you're not feeling this. Stages C and D are the more clinical conditions, meaning that not only do you have a weak heart, but you've had or you have ongoing symptoms like shortness of breath or fluid retention and required hospitalizations or fatigue. So the latter stages are really the more advanced disease where it's actually, you're feeling it. And A and B are really the preclinical stages where this is where we really like to find patients and really focus on treating risk factors.
Mhm. And what are the causes to heart failure?
Okay, so, and Jonathan, by the way, you know this stuff as well. So please do step in if I'm missing anything, or if you feel like you want to add anything at all. So heart failure is, when you say what are the causes, there's so many different causes, and I broadly place, patients into categories as being either ischemic or non-ischemic. And what that means is it caused by heart attacks, or is it not caused by heart attacks? So, thinking about the ischemic group, which is the, heart attacks causing a weak heart, we think about what causes a heart attack? Well, it's high cholesterol, high blood pressure, uncontrolled diabetes, genetic factors that we can't always control so well. And smoking, of course, all of this stuff leads, adds to your risk. The non-ischemic causes, again, sometimes there's viruses that cause weak hearts, and we don't understand this very well. Very rarely post-pregnancy you can have heart failure. So there's so many different causes, but I generally kind of categorize patients as, is this a heart attack issue where we have to treat risk factors like diabetes and high blood pressure, or is this a non-heart attack issue where maybe a virus, maybe we'll never know why your heart is weak, but these is kind of the broad causes that we put patients into.
I think too, what's important, I think, with all of that is recognizing that, pre-heart failure care is so important. So it's really understanding your body and what's happening with your body, and knowing that if you have hypertension, you should be treating that before it becomes a bigger problem, because things like hypertension or coronary artery disease or even viral illnesses, to your point, can end up with you having this kind of chronic condition. So treating them earlier on is always better. That's just my 2 cents.
That's absolutely it.
Yeah, and you mentioned something very interesting to me. You said it could be caused by a heart attack or not, but I was thinking, so what comes first? I thought heart failure could, have a heart attack as consequence, but now it looks like it could be cyclic for some reason.
Yeah, and I think, again, it's really, we know the risk factors that are involved with developing heart failure, and if you let your diabetes uncontrolled for years and years and years, you're going to get a heart attack, and that heart attack might weaken the heart enough to give you heart failure. Not all heart attacks equal heart failure. And certainly when you have heart failure, it doesn't necessarily mean that you've had a heart attack in the past. They're two different conditions, but yes, one can lead to the other, meaning heart attacks in just the right area, losing enough of the heart muscle, can cause that weak squeeze and that, that distinction of heart failure or not.
Mm-hmm.
But it's really a spectrum. You're absolutely right. I think, the heart disease, heart failure is really at the end of that spectrum, which hopefully, we can avoid if we intervene early enough, as Jonathan was saying.
Mm-hmm. Now, you've mentioned a few things that could cause heart failure. You've mentioned hypertension, diabetes, any high cholesterol, any other causes for heart failure that we haven't mentioned?
Yeah, so there's, one big category is genetic diseases, genetic causes. And those are either congenital or things that develop over time. So that's kind of probably the rarest form of heart failure. But again, this is something we think about when we encounter a patient for the first time with heart failure. We say, well, what are your risk factors for developing heart attacks? And then what about everything else? Is there something else about you? Do you have a strong family history of heart disease? Is there a strong family history of heart failure? And then that kind of raises our suspicion to looking into this other category. Certainly the rarest form, but I think it's still equally important for us to understand.
I think too, it comes down to, when you're thinking about heart failure, there's modifiable risk factors and there's non-modifiable risk factors. And so like if you have family history, if if you kind of have like those long-term coronary artery disease or long-term hypertension, those are less modifiable than things like long-term alcohol abuse or smoking or illicit drug use. Sometimes, cocaine can lead to heart failure. And so if you're thinking about preventing it, you really have to kind of put those two categories and understand what can be modified versus what can't be modified. And that's where I think you would have a conversation with your primary caregiver or a cardiologist and really understand what you can do for yourself for prevention.
Mm-hmm. And Darren, now you're mentioning something really, really good. Symptoms. So do we always present symptoms, or can heart failure go undetected for quite some time?
So it can go undetected, absolutely, especially in those earlier stages of heart failure and kind of like those pre-heart failure stages. It's kind of similar to hypertension where it's silently happening over time. And a lot of times by the time you're symptomatic, and correct me if I'm wrong, please, Dr. Murthy, but by the time you're symptomatic, you are in a more advanced stage, and it is more, it's going to be a chronic condition at that point where it's more about maintenance and keeping yourself out of these exacerbations and kind of symptom management at that point.
Yeah, that's absolutely, I totally agree with that there's definitely early disease where patients don't necessarily feel anything. Or, what I find is the younger patients generally handle this a lot better. They develop ways to compensate. They're really in good shape otherwise and don't necessarily feel this until it's really, advances. So yeah, and that I think is the whole kind of point of the AHA staging system as well, just to say, yeah, there is a group that may not feel this. The A and B group are not going to feel this, but they still have disease. So it's equally important to be aggressive with those groups too.
So how do we know if we are in that stage A and B? Yeah,
so the stage A and B is really involves risk factors, and mostly stage A, which is the earliest kind of staging system of heart failure. And what we say is, what are your risk factors? We say, are you a smoker? Do you have diabetes? Do you have high blood pressure? All of these things kind of predispose you to development of heart failure. So these are the things that we would screen you with. And, and those are the things that we aggressively try to attack. So if you've had long-standing high blood pressure, uncontrolled, and, you're stage A technically, and that's really equally important to treat as if somebody that has a low squeeze, pump squeeze, and has a weak heart. Equally important to treat the early groups as well. Mm-hmm. But yeah, this is a conversation that you would have with your cardiologist, your primary care doctor. What is my risk of developing heart failure? And and that's clinical heart failure. So that's really the focus on the risk factors here.
Dr. Murthy, you have me thinking about comparing heart failure with cancer a little bit, right? Like cancer also has stages, and it's much better if we detect cancer in the earliest stages. Sounds like what we're talking about here. But then for cancer, we have like so many screenings. Are there screenings also for heart failure, so that if we're not feeling anything, or I don't know if I have high cholesterol and things like that, I can get.
Yeah, so in patients that have higher risks, I do a screening echocardiogram, or if, patients have noticed something, say, I feel like I'm a little bit more short of breath when I walk up the stairs lately. And it's somebody with hypertension or somebody with diabetes. I say, why don't we just look at an echocardiogram? An echocardiogram is a very quick, simple, non-invasive test, no radiation. It involves an ultrasound probe to your chest. And what we do is we take pictures of the heart, we take measurements of the heart, and we can actually see how strong is that heart. And that's the perfect screening tool, really, to say if somebody that's worried or feeling anything out of the ordinary and wants to be absolutely sure, echocardiogram is a perfectly good place to start.
Mm-hmm. You mentioned some of the symptoms, shortness of breath, if you're going upstairs and you feel a little short of breath, right? Anything else that we should be aware of?
Oh, absolutely. I mean, shortness of breath is kind of like the classic that everybody knows about, but also, if you start having exercise intolerance, if you're someone who's exercised and then all of a sudden you just can't go as long, or you're just not able to tolerate what you used to be able to tolerate, that could be a sign and symptom. Difficulty laying flat without extra pillows, kind of like feeling that you can't breathe whenever you lay flat, could be a sign or symptom. Swelling in the extremities, or rapid weight gain. It shows that you're kind of retaining fluid. Those are all other symptoms that maybe aren't as well known as that kind of like classic shortness of breath that comes with heart failure.
Mm-hmm. When do we need to run to the emergency room or see a doctor? I guess see a doctor first and then emergency room. I don't know.
Yeah, and I always tell patients, your body, and anything that you feel is, this is just very atypical for me. This is not feeling right. So shortness of breath, feeling like you can't get enough air, don't wait. Go to the emergency room. Just get it checked out. Something like, oh, it's subtle. I've noticed that I can't walk up the stairs, as well as I did 2 months ago. That's when you pick up the phone and call the doctor, and say, hey, let's just screen this. But your body, and when to worry about symptoms. You should kind of have a good sense of, this is way out of proportion to anything, or, and so I say, set the threshold very low to go to the ER. Don't wait around. The worst thing is to have symptoms and just ignore them. So, I think trust your instinct a little bit.
Mm-hmm.
Darren,
I think I think that's a really good point. And I think another aspect of that is kind of like really knowing your body. You may know that you feel off, but you really should keep your regular checkups, go to your doctor regularly, understand kind of where your blood pressure is. Are you hypertensive? Are you pre-hypertensive? Are you being treated for that? It's really important to understand your own health and know where you are. Because even once you get to the ER, they're going to want to know, do you have a history of hypertension? Is this brand new for you? There's a lot that leads up to heart failure and really any disease process. And the more you know about yourself and the more self-aware you are about your health, the better off you'll be in the long run. And that's for anything.
Absolutely.
Are there any changes that you need to do, lifestyle changes, I guess, after you get diagnosed with chronic heart failure?
Yeah, so I think that's a really good question. And, I would lump this into a couple of things. So one is diet, and the second thing is lifestyle. The diet, it has to be a complete lifestyle change if you aren't already following low sodium and fluid restriction. So the idea behind this is that anybody with heart failure, patients with heart failure, generally won't be able to tolerate high salt loads like the normal person. I always say, for example, if I eat a bag of potato chips, I won't necessarily feel anything differently tomorrow. Whereas a patient with heart failure would eat a bag of potato chips, they may notice, what, I'm a little more swollen, and I might have a little bit more shortness of breath. You hold on to that salt, you hold on to that fluid, unlike the normal heart. So the heart failure patients tend to be very sensitive to salt and fluid. So we always kind of put a restriction on that. And it's very hard. It's not about the salt that you're putting into your food. Everything out there has salt in it. Mm-hmm. So it has to be a complete kind of change in lifestyle where you start to look at labels. What's in this stuff? How much salt am I getting per day? And we say about 2 grams, 2,000 sodium is really the limit, the upper limit, where we say, anything more than that, you probably won't be able to excrete that very well. You might hold on to it and you might fill up with fluid. And fluid is the same thing. Liquids, people think, well, I'm on a water pill, maybe I need to hydrate, but that's actually the opposite of what we're trying to do. We're trying to keep the water off. So the more that you put in, the harder it is for us to kind of work with the medicines and take fluid off appropriately. So there is a big, kind of fluid restriction as well. So we say no more than 1.5 liters of all fluids. So that's juices, waters, teas, everything kind of fits into 1.5 liters, which is roughly 50 ounces or so. Those are the big dietary guidelines that I always stick to. And you got to just know what's in your food. Alcohol, alcohol is loaded with salt. So this is really just important to be aware of, what can I take that wouldn't make me swell up the next day? And you're going to notice. You have some Chinese food one night. Guess what? Tomorrow morning, you might need an extra water pill. You're going to wake up short of breath, maybe with some more swollen legs, things like that. So you're going to have to really pay attention to the diet. The exercise part of this, and we're happy to have good data that guide us now that says that exercise is always safe. It's always healthy. It's never dangerous, no matter how weak your heart is. Now, that's not saying you should go from 0 to 100, but you should maintain a good amount of cardiovascular health. And we say cardiovascular exercise like walking, biking, things like that. You want to avoid heavy lifting. Heavy lifting causes high blood pressure and spikes in blood pressure, which we want to avoid. So anything where you have to bear down or, we avoid that. But certainly cardiovascular fitness, extremely important, extremely important.
Yeah, I think that's a good point. You have to think about conditioning your heart for like longer tolerance. You don't want to your point, you don't want to be spiking your blood pressure. You don't want to be doing anything like that. But you want to be able to keep things in as fit shape as they can be, right? So that cardiopulmonary exercise is so important.
Darren, would it be possible to explain what salt does in your body, or sodium? Because I know about this, and I know a lot of people do, and as a registered dietitian, we go through this all the time, and you restrict foods, but I feel like if people don't understand what it really does physiologically, they're like, and it's very important. So could we explain that, like what salt does and what the fluids do as well in the heart, and why we need to restrict them?
Sure, absolutely. And I think that's so important. You really want to know why, right? So salt naturally, and someone who's perfectly healthy, salt is going to cause you to retain fluid, like a higher intake of salt. It can increase your blood pressure. Just so like myself, I'm fairly healthy. I go to the gym regularly. If I go tonight and have some Chinese food or something that's really high in salt, I'm most likely going to be retaining some fluid after that, because it just naturally will do that. My heart works perfectly fine. And so it's not something that I'm thinking about how much fluid is going through my heart, because that's really at the end of the day what we're thinking about, right? How much fluid can your heart, how much volume can your heart take as it's pumping? Because someone who's in heart failure, your heart is not pumping as much volume through, and it's not getting your blood out to the rest of the body in a as healthy a way as a normal heart. And so we want to do everything that we can to preserve what's happening with your heart, even if you are in heart failure. And that's why you want to reduce the amount of work that it's doing as far as like how much it's pumping through, what volume is pumping through. We want to make sure that we're not adding anything to that work. And that's why keeping those fluid restricted, not adding too much fluid into your body and not retaining fluid is so important, because all of those things increase the work of your heart. And when you have heart failure, probably, the fluid that's already in your body is backing up because it's not going through the heart the way that it's supposed to. And so the more you add to that, the worse off you're going to be. So that swelling that we talked about earlier, that lung congestion that we've kind of like talked about, that causes the shortness of breath, it's just going to get worse and worse and worse until you end up having to go to the hospital and end up kind of like in an emergent situation where we're giving you, instead of a water pill, it's a drip, and you have to be put on a drip in order to take that fluid off as quickly as possible so that you can get back to your normal.
Yeah, that's very interesting, and I'm trying to visualize that. I'm a visual learner, so I'm trying to visualize that. So In summary, I will say, you know, the more salt you eat, the more water you retain, the more water or liquids in general you retain, the harder your heart is going to have to pump all that liquid, and it's not going to be able to keep up with it because your pump is not working very well. And then that liquid is going to go everywhere else in your body, especially the feet. That's why you get swollen feet, correct?
Yep.
Got it. Yay. I'm a good student.
Thank you for paraphrasing.
That was good.
Okay, how long can you live with heart failure? I think that's a question that scares everybody. You know, how long do I have to live?
This is like the most dreaded question for any healthcare provider, I have to say. But, you know, the one thing I tell patients is, listen, don't ever listen to anybody that tells you how long you're going to live. Nobody knows that. But here's things that we do know. We know that, you know, if you control the risk factors, of course, we know that we look at all our studies in the past, patients with heart failures don't have a normal survival as compared to the normal population. We know that. But that says nothing about the individual sitting in front of you in the office. So it really is about how well are we controlling your risks? How well are you taking care of yourself? So I hate that question because I said, don't focus on how long you're going to live. Let's take care of you now and make that, you know, make that as long as possible. But of course, you know, I have to say that no, you don't have, you know, patients with heart failure generally don't have as long of a survival as a normal patient. But that's not you. You know, you're gonna take care of yourself. You're gonna, you know, do all the right things and give yourself the best shot of a normal long life. I don't know, Darren, how do you answer that question when you get asked?
I agree with you 100%. 100%. I told them to ask it out, but I agree with you. Every individual is different, right? So it's nothing can be so generalized that you can say to the person sitting in front of you, oh, well, your life expectancy is this now because you have this chronic illness, because I may be more compliant or less compliant than the next person, and that compliance and how, again, coming back to how well you know your body, how often you get checked up, are you regularly checked up, you know, all of those things contribute to lifespan and longevity or lack thereof, because it really, you know, a lot of it depends on that person.
And after you're diagnosed, how often do you need to see the doctor to monitor your condition?
So this is also a kind of a patient dependent question, but you know, it also depends on what stage of heart failure that you're in. If this is the preclinical stage, you perhaps don't need to be followed so frequently, 3 months or so, for making sure your blood pressure and all the risk factors are well controlled. But in patients that I see that with pretty advanced heart failure with very weak hearts, I see them sometimes up to every 2 weeks just to up titrate and get those doses of medicines perfect, make sure that they're on all the right stuff. So it could be as frequent as, you know, every 2 weeks as needed. But, you know, once you're well and on a stable regimen, 3 to 6 months is reasonable. And
are people with heart failure candidates for a heart transplant?
Yeah, so I'm glad you asked, because this is really what I do down here in the Bronx. And you know, I'm a transplant cardiologist, and these are the patients that I see mostly. But I have to say, my biggest goal when I see patients every day is to avoid ever having to get to that point. You know, that would be the best thing. So what I can tell you is that, yes, there are a minority of patients with heart failure that will need a heart transplant sometime in their life. But this is something we try to avoid with all the good stuff that we have, you know, in 2022. So yes, there are, and you know, the heart transplant is a wonderful option if you need it. And that's the big, if you need it. If you need it, the heart transplant in 2022, done at our center, you have upwards of 90% survival at 1 year in a disease that would normally not be fatal at that stage. Okay, so it is a wonderful option if you need it. But my goal is not to talk about the transplant. My goal is to say, how can we prevent ever having to talk about the transplant? But yes, there are patients that who need it, and it's a wonderful option for them.
And at what stage do you need to think about that? A, B, C, D, E, I guess?
It goes up to D, and once you're stage D, or once you've had, and there's things that I look at. If despite medical therapy, despite all the good stuff that we have in 2022, patients can't stay out of the hospital. They keep coming back to the hospital, keep filling up with fluid. We need to think outside the box. We need to think about something else. So this is really the stage C and D class that we target. We say, hey, listen, it's time to start thinking about this, because every single time you go into the hospital, the heart takes a beating, so to speak, and we don't want to wait until there's no options before we start the discussion. So the hardest part of my job is to kind of say, hey, listen, when is the right time to talk about any of this? Or do we have other options other than transplant, and use all our, tools that we have?
Mm-hmm.
So, there's signs that I look for, as and a lot of that has to do with how well the patient feels and how many times you've been in the hospital and how well the medicines are working. There's things I look for.
Mm-hmm. So tell us a little bit more about the medicines, Dr. Murthy. What kind of medicines are those? Do they have side effects? Something that we should be concerned about or not?
Yeah, so just speaking about the medicines, I'd like to preface it by saying that prior to 1986, we had nothing. We had bed rest. We had, really nothing that kind of changed the trajectory of this disease.
Wow.
So we're really lucky in 2022. We have, 4 different therapies, that can improve survival, and really some that have really good data to actually reverse the heart failure process as well. So one of the things that we do and we focus on in the heart failure clinic is to get our patients on these medicines, these 4 different combinations of therapies. All of them to some degree have effects on blood pressure control.
Mm-hmm.
So, you're going to drop your blood pressure a little bit, which is why it's done slowly and done carefully, multiple visits. There's certain medicines that are excreted through the kidneys, so we have to be very careful with that.
Mm-hmm.
Some medicines can make your potassium level higher, but we feel that the risks of these medicines, the small risks of the kidneys and the blood pressure, are completely outweighed by the tremendous benefit that we see in survival for these patients. So the biggest thing is that before we start any therapy, say, hey, here are the things that you can look out for. You may see. Here's the things we watch for. And we frequently check blood work after changing things and starting things, just to make sure that things are stable. So there's ways that we do it in our clinic where it's safe. We start slow. We have informed discussions with the patients, and we say, listen, I wouldn't do it if the benefits weren't so great to your heart.
Oh, well, that's good news, actually, that you say that at some point, with the medications, it could be reversible.
Yeah.
It's really great to hear.
Yeah, absolutely.
Okay.
The most important thing with any medication too is making sure, like, and I think Dr. Murthy really explains it well, like beforehand, understanding what this medication, the normal things that this medication will do to you, the normal side effects for the medication,
Mm-hmm.
and then continuing to take the medication once you started. Like, it's so important that if you really want to treat this, if you want to have long-term success or longevity, taking your medications as they're ordered, and having a really good open line of communication with your providers, with the heart failure specialist, with your cardiologist, with your primary doctor, about what's going on with you in the medication. You should always take your medications and never stop anything unless you've talked to your provider first. So that's something I think that's important to think about.
Yeah,
Absolutely.
And I'm thinking, it's very important to really have your physicals done every year, check your cholesterol, high blood pressure, all of that, because otherwise, how are you going to know?
You got to know your risk.
Exactly. Better safe than sorry, as they say. And now we have a few questions from our attendees. Is there an age group with higher risk for CHF?
Yeah, and I can tackle that. So, the prevalence of heart failure increases with age for sure. At the, at the 9th decade, 8th decade of life, the incidence of heart failure is quite high. It's much higher than as in the 2nd decade and 3rd decade of life, so there is a age-related increased prevalence. But once you start stacking risk factors, the hypertensive 80-year-old, their incidence of prevalence of heart failure is extremely high. So it's really the risk plus the age. So there is a definitely, after around age 60 is when we start to see a lot of the heart failure. But not to say that it can't happen in the younger ages, but that's really the time period where we start to see the higher prevalence.
Younger people, and I'm talking mostly like high school students or young people in college that start taking steroids. I've seen that one of the consequences is they can't just be playing a football game and just die of a heart attack right there because of the steroids. So is that chronic heart failure? So steroids.
Yeah, so that the heart failure in the younger ages are generally not caused by these risk factors that we talk about, the hypertensive, diabetes. These are all, a lot of them are, you can group them into either the genetic diseases that we just can't control for, or they're the toxic substances, which is a very highly prevalent thing, especially in the young athletes. And we've seen a handful of steroid myopathies, cardiomyopathies. And so, yeah, so that is a big problem in the younger age group, and fortunately it's still quite rare, but we do see that. And then of course Darren had mentioned the cocaine and drugs and even alcohol. There is a entity called alcoholic cardiomyopathy, and this is what we see in the younger ages. So the older ages is associated with traditional risk factors. The younger ages, it's more of these toxic / genetic causes.
That's crazy.
Yeah.
Another question: if a parent or sibling has risk factors such as mitral valve prolapse or diagnosed with a leaky valve, should someone think about going to a cardiologist or just be screened by an internist is okay? Yeah, so in this day and age, I have to say this one area that we didn't really talk about too much is this idea of valvular cardiomyopathy, meaning heart failure caused by valve problems. We have so many tools now to fix these valves without surgery, and we have fairly good ideas on how and when and at what point we should fix these things. So if you have known mitral valve prolapse or one of the, these conditions that's actually quite prevalent, the screening echocardiography should be done at a regular basis. Now, whether a good internist can do this, whether you want to see a cardiologist once a year and the internist in the middle, that's really kind of a decision up to you, but it's really imperative that at least you have screening echocardiography performed at frequent intervals, or if you're your symptoms arise. So the valvular cardiomyopathy group is a little bit different in the sense that yes, it's a risk factor. I have to say most patients with mitral valve prolapse never need anything in their whole lives. We see it quite a bit, and they never need intervention. But the important part is saying, well, when do you need intervention? We're watching you at frequent intervals every year or so and getting echocardiograms. I do think it's a good idea to have a cardiologist involved, but not necessarily the one that's going to be doing the echocardiograms every year. And of course, just so that somebody is aware. And it's also important for you to know there's options. It's not always surgery.
I think that's such a good point that, for everything, a conversation should be had, right? Whether it's with your internist or with a cardiologist or any, like, some sort of professional conversation should be had with a medical professional, if there's concern.
Thank you. Here is another one. It sounds like getting a regular physical exam is important to monitor symptoms that could lead to heart failure.
I mean, getting a regular physical exam is important to monitor everything, right? Because beyond heart failure, even if you just have hypertension, I just did a presentation on earlier this week, and it's the silent killer, because you could slowly, your blood pressure could start to rise and you not even realize it, and it's causing all this damage within your body and you don't know it if you're not getting checked out regularly, if you're not taking some sort of regular blood pressures. And so for everything, you know, getting that annual physical, or even more frequently depending on your condition, is so important.
Mhm. And Jill is asking, patient on high blood pressure, water pill, cholesterol medication, family history, but echocardiogram shows normal. How much risk of CHF is there?
So you're just stacking all the risks here. Okay, so you know, listen, I won't quote you.
Oh, do you want to make it more complicated?
Yeah, I won't quote a percentage, but I think the most important point in this question is to say, well, are you you know about these risk factors?
Mm-hmm.
So are you controlling them? And that's the big thing. Are you watching the salt? Are you doing your part in the exercise and the limitation of fluid restriction and things like that, and taking the medicines as prescribed and keeping your blood pressure within our range? That's really the most important thing. So controlled risk factors versus uncontrolled risk factors, that really determines the development of heart failure. So it's really about the patient here, and well-controlled risk factors, I wouldn't worry, you know, as long as you're being followed frequently and you're doing your part and you're keeping the blood pressure where it should be and taking the pills. I wouldn't stress about the you know, the development of heart failure.
So even if you are on all these medications, if you go in to have your physical and everything chills out to be okay, your blood pressure is okay, cholesterol is okay, you shouldn't worry.
Yeah, you shouldn't worry, because, you know, again, this is the best tools we got. You're taking care of this. And so, you know, I think as long as we're doing our part here to mitigate any, you know, the development of this, it's just important to keep that in mind as a reason why we keep going with the pills. You say, I feel fine. Do I need all these pills? Yes.
Yes.
That's the bottom line.
Right.
Yes, because of this risk factor concept. That this is what we're trying to prevent 5 years down the line, not now.
Yeah.
Right.
So I will say the problem is not driving, it's driving drunk.
That's right. That's right.
Very, very good. Yep.
Darren, you were gonna say something.
I just to reiterate that, you know, it's so important to just stay compliant. You know, you're feeling okay because you're compliant with your medications, right? You're kind of keeping these things in as much control as you can, and that's the most important thing. So.
Mm-hmm. Yeah, and you know, I know from personal experience, also from a lot of my patients, it's like sometimes you get tired of watching.
You get sick of all these pills,
exercising, and all those pills, and you're like, oh my God, you know. So sometimes you like to take breaks, but they should be very short breaks. You know, that's what I tell my patients. Okay, enough of a break. You need to get back on everything. You need to get back on track. And you need to start taking control of your health again. And, you know, as you were saying, Dr. Murthy, I mean, thank God there are some medications out there now that can help with all of this.
We're in a good spot. We're in a good spot for this stuff.
That's great. That's very hopeful news, actually. Okay, let me see. I don't think that we have any more questions. So to all of our participants, it's now or never. So please, send your last questions. In the meantime, any last thoughts, Dr. Murthy, Darren?
I mean, I'll say, going back to the whole medication thing, you know, it's very easy when you feel good or you're not showing symptoms to say like, I'm fine, why do I have to take this? With any medication, I like to think about a worst case scenario. So and think about why you're taking that medication. So if you're someone who has, let's say you have seizures and you're taking medication to prevent seizures, right? If you go off of that medication, the possibility that you could have a seizure is fairly high in your mind. And so you're going to continue taking that medication because you don't want to have that seizure. And so really anybody who's taking medication for anything should think along those same lines. You know, if it's for cholesterol, you don't want the cholesterol to get out of control. It may not be something that you see. It may not be something that's completely like evident right in front of your face, but think about it like that seizure. I don't want to have a seizure, so I'm going to take my seizure medication. I don't want my cholesterol to go up, so I'm going to take my cholesterol medication. And the same thing with any because you're on these medications for a reason. And the minute you go off of them, whatever you were on them for is going to flare back up again. So that's just, that's my take on just medication compliance in general. Think about the worst possible thing that you could take medication for and what's going to happen if you go off of that medication. And it works that the same way across the board for any medications.
Yeah, and I leave the medications talk for another time, because I know that we could talk about medications all the time. But it's true. I mean, some people feel that, oh, you know, everything is okay, I'm feeling fine, so I don't take it anymore. You know, they take it like Tylenol. That's what I always say. This is not Tylenol.
Right.
You know, this is not going to go away. It's going to come back if you don't take it. So if you're listening to this, please take your medication. If you forgot your medication today, go get it.
Yeah.
And it's hard. And I completely get it. You know, just, you know, as someone guilty of that herself, you know, it's hard to just take pills more than one time a day. But, you know, we just stress it's an open communication thing as well. You know, just talk to us. We work through, if there's something about the medicines you don't like, you tell us, and we'll work around it. There's always options, there's always things, but we want it to work for you.
Yep.
Oh, and thank you for saying that. Yes, because sometimes people, you know, they don't disclose side effects.
Yeah.
They just think they just have to feel that way. And, you know, it's good that they tell you what it is so that you can change the medications or play around with the doses or something.
That's right.
Yeah,
Yep.
That's great. Well, I don't think we have any more questions. This has been very, very informative. I've learned a lot myself. Now I know exactly how things work, even better for me. I can help my patients more and my family members. So thank you, Dr. Murthy. Very nice meeting you. I'll be calling you again now that I know you.
Absolutely. Absolutely.
Ask
Bring it on.
Darren, he can attest to that. And I was like, I was just saying earlier, like, now I work more with you than anyone else.
There you go. I'm here for you.
Darren, it's always a pleasure to see you. And thank you to all of our attendees. Please join us next week. It's Pride Month. We're celebrating it proudly. So we are going to be closing. Guess who's going to be there too. Again?
I'll be back again.
Darren and other of our colleagues are going to be here. We're going to be celebrating LGBTQ month. So please come listen to some stories, testimonials. It's going to be a very heartfelt event next week. And I'll see you soon. Thank you so much.
Thank you, guys.
Thank you.
Bye-bye.
Bye.